Okay, very good. Well, good afternoon, everyone. Just going to look for a sound check here. Pam, how's the sound there on your end? Okay, very good. Well, thank you, everyone, for joining us today. My name is Omar Khan. I'm head of the Delaware Health Sciences Alliance, and the DHSA has a long and proud tradition of supporting research, education, and service within our health sciences, and specifically within the health sciences partner institutions in the Delaware Valley. And that is those are presented by many of our colleagues who are here today, from Nemours, the University of Delaware, from Christiana Care, from the Philadelphia College of Osteopathic Medicine, from Thomas Jefferson University, from the Delaware Academy of Medicine and Delaware Public Health Association. And we thank all of our experts for being here today, and they will introduce themselves in due course. The annual research competition, which we affectionately sometimes subtitle or call Shark Tank, is a wonderful opportunity for us to hear from our colleagues who are developing innovative ideas that might need some grant funding, and they have collaborated across the DHSA institutions in order to make that happen. Now, last year's event was held live at the University of Delaware, and this year's event is held live again, and this year it's held live over the internet in our new world where we are affected by COVID-19. But we're so grateful to all of our partners to rising to the challenge, for being able to continue all our terrific work together in this brave new world and this online format. I want to send some couple of special thanks out. First of all, to our distinguished panelists who will introduce themselves, as I said, in just a moment. And I want to thank in particular Pam Gardner, who is my right-hand person. She's the program manager for the Delaware Health Sciences Alliance. And Pam has been such a stalwart and has organized this entire event today. And with Dr. Kate Smith. Kate works with the Delaware Academy of Medicine and DPHA, one of our partners, and has been, again, a terrific support and leader in this event. Last year's event, some of you will remember Kate from that as well. And she's back this year teaming up with Pam to make this event a success. So again, thank you very much. Thank you to those of you who took the time to submit for our competition, and we will be hearing soon from the top finalists in that regard. So thank you very much for being here as well. Pam, let me turn it over to you there, and Pam will be our host for much of the remainder of this program, and we will introduce the panelists and get some housekeeping done, and then on to the first session. So Pam, over to you.
Great, thank you, Dr. Khan. Welcome everyone to the 2020 DHSA Research Competition. Please note today's competition is being recorded. The 2020 DHSA Research Competition call for abstracts required a COVID-19 population health research initiative with collaboration among at least 2 DHSA member institutions. The 4 research teams presenting today represent the top 3 score finalists from our first round blind review and scoring of all abstracts received by our panel of judges, who will meet in just a moment. I'd like to take a moment to thank all of the teams that submitted abstracts for consideration. The format for today's competition will provide each team with 15 minutes to present, followed by 10 minutes for questions from our judges panel. If time permits, our virtual viewing audience will have the opportunity to ask questions as well. Audience members may submit questions via the Zoom chat function. Judges will score each group, and the scores will be tallied so that at the end of today's competition, we will announce the 2020 research competition winner and the recipient of the DHSA $50,000 research grant. As Dr. Khan mentioned, a special thank you and acknowledgement to our colleague, Dr. Kate Smith of the Delaware Academy of Medicine and the Delaware Public Health Association for her partnership and support of our event today. And now I'd like to go on to our introduction of our sharks. Being that we're in a virtual format, I will call your name, and then if you could give a brief introduction. Dr. Funanich, we'll start with you.
Good afternoon. My name is Vicki Fananage, and I'm Operational Vice President for Research at Nemours Alfred I. DuPont Hospital for Children, and I look forward to hearing your presentations today. Good luck.
Thank you. Dr. George Weinstein?
Good afternoon, everyone. Mindy George Weinstein from the Philadelphia College of Osteopathic Medicine, where I'm the Chief Research and Science Officer. I've been involved in medical education and my own research for over 3 decades, and both of these activities continue to fill my plate today. I too look forward to your presentations. Thanks very much.
Thank you. Mr. Gibbs.
Yeah, Tim Gibbs with the Delaware Academy of Medicine, Delaware Public Health Association. Welcome to all of you who are going to be in this competition today. We're truly impressed already with the abstracts that we read and looking forward to your presentations. Thanks.
Thank you. Dr. Levine?
Hello, Brian Levine here. I'm the Associate Chief Academic Officer at Christiana Care and former Program Director for the Emergency Medicine Residency. And I oversee the undergraduate and graduate medical education here. And I'm excited to see these research proposals and look forward to a great day. Thanks.
Thank you. Dr. Stanhope?
Good afternoon. I'm Stephen Stanhope from the University of Delaware, where I'm the Associate Vice President for Research. My primary focus is advancing biomedical research in the state of Delaware, and I use the Delaware IMBRI program as the primary tool for accomplishing that. Good luck, everyone, today. The projects that we read were very exciting. We're looking forward to the presentations.
Thank you. And last but certainly not least, Dr. Whelan?
Hi, Dave Whalen. I welcome everyone and look forward to the presentations. I serve as the Senior Associate Provost for Clinical Research at Thomas Jefferson University.
Thank you. And now Dr. Smith will elevate our first group to presenter status. Kate, once they are ready, if you could let them know the timer is set, and then the floor will be theirs. Good luck.
Yes, the timer starts now. Group 1, it is 2:09. You have 15 minutes.
Hello, can everyone hear me all right?
We sure can.
Perfect. All right. So my name is Ariella Anthony. I'm a second-year medical student at the Philadelphia College of Osteopathic Medicine. On behalf of Dr. David Paul and representing Christiana Care and Dr. Thiel Anthony representing Nemours Pediatrics and myself, I just want to say thank you for your consideration. So I want to start with a few clinical vignettes of some patients from Nemours Seaford. We've had multiple mothers bring in their newborns with significant concerns over how their infection with SARS-CoV-2 may have an impact on the future growth of their children. One mother who was infected with the virus via her husband, who worked at a Sussex County chicken plant. The infant was initially seen with the father until 2 weeks after birth, and this mother was very concerned about how the baby would grow because of her infection. Another mother, a physician working at a local hospital, tested positive for COVID-19 during her pregnancy, and at every well visit, she has questioned if her infant is exhibiting symptoms of COVID-19 infection. Finally, a mother who works in the local emergency department developed symptoms so severe that she was intubated and stayed in the hospital for 3 weeks, unable to care for her child. All of them have the same types of questions. Will my baby be okay? Will they grow normally? And is there anything that I should expect because I had this infection? Our research is titled Epidemiological Study of Infants Born to COVID-19 Positive Mothers. Novel viruses have been proven in the past to have clinical effects on newborns via maternal infection, notably the 2009 H1N1 pandemic, and of course, Zika-linked birth defects. Although data from the CDC suggests that pregnant women are not more susceptible to infection or death than the general population, they may be at risk for increasingly severe illness requiring intensive care unit admission and mechanical ventilation more often than non-pregnant women. So far, COVID-19 illness during pregnancy has been linked with adverse perinatal outcomes, including miscarriage or stillbirth, intrauterine growth restriction, and a 43% incidence of preterm birth. Additionally, recent CDC data has demonstrated that COVID-19 targets mothers from racial minority backgrounds disproportionately. To date, however, there's not adequate information regarding how infection in a mother may affect future growth and development of newborns, regardless of newborn infection status. The primary aim of the study is to follow infants born to SARS-CoV-2 positive mothers in Delaware and gather data on the health effects, if any, of maternal infection on the newborn. Mothers testing positive for SARS-CoV-2 will be identified and matched with infants within the Delaware Children's Health Network, which is a clinically integrated network of 12 community primary care private practices and 12 Nemours pediatrics practices. What's really unique here is the fact that we're searching for a baby through the lens of the mother. We want to identify these positive mothers first and then assess the baby. Newborn health will be assessed in the 30 days and 6 months following birth. Main newborn outcomes will include postnatal testing for SARS-CoV-2 if applicable, readmission, emergency department utilization and growth. Other maternal and newborn variables assessed will include sex, race, ethnicity, gestational age, mode of delivery, and placental histology. Because we are identifying babies born to positive mothers and not just searching for positive newborns, we can evaluate whether or not an infection early in the pregnancy may affect growth and development regardless of newborn infection status. And we are really interested in the potential intrauterine effects of maternal infection. The newborns born to SARS-CoV-2 positive mothers will then be matched to a cohort of healthy babies born in 2019. Control data from 2019 will be used to avoid the confounding effect of mothers who may be infected with SARS-CoV-2 but not captured through testing a contemporaneous cohort. Thus, we can determine if early infection in the mother contributes to different growth outcomes than that of a newborn whose mother was not infected in 2019. Analysis will be stratified by race, ethnicity, and county of birth. Data will be extracted via chart review and input into a secure database. Chart review is necessary in this case because the lack of longitudinal data systems makes collection difficult. We need to identify the mother first and then link mom with her baby. Aside from Medicaid data, which has a significant time delay and is not necessarily representative of the entire Delaware population, there are no other systems that allow for this type of review. Additionally, coding nomenclature for babies born to COVID-19 positive mothers was not available until around July or August of 2020, which means that without chart review, we might miss some of the babies. Data collection and organization will be performed via collaboration with Research Electronic Data Capture or REDCap programming. The two groups will be compared using standard statistical analysis. Continuous variables will be analyzed with ANOVA or Mann-Whitney U-test, categorical variables by chi-squared, and logistic regression will be used to account for any confounding variables. The study will provide valuable clinical information if the novel coronavirus does affect infant development, and it might reveal some insight as to how the infection disproportionately affects minority populations in Delaware. A secondary benefit of the research and one of our sustainability plans will be the creation of the database of newborns, which will allow for future research on longer-term infant growth and development. Once the database is created, it could be used to follow long-term growth and development outcomes. Despite 10 months of data during the SARS-CoV-2 pandemic, there's still a paucity of data beyond initial hospitalization, and it is difficult to know what to expect or how to follow babies. Although outcomes of newborns infected tends to be favorable, short and long-term data on growth and development of newborns has yet to be uncovered. We suspect many babies will test negative if they are tested, but there still may be short and long-term effects on fetal growth and development in this population to follow up on. Delaware provides us with a unique situation in terms of studying newborns. We estimate that there may be 170 or more mother-baby dyads between ChristianaCare, Bay Health Hospital, Nemours, BB Healthcare, and Tidal Health Nanticoke. Additionally, Delaware provides representation for many different populations, including rural and urban areas, and representation from minority groups. With the data from these babies, we may be able to uncover important clinical expectations of newborns born to COVID-19 positive mothers that may be used to better counsel mothers and families on outcomes, and we may be able to ease some of the concerns and confusions surrounding the novel coronavirus. Again, on behalf of the research team, we want to thank you for giving us this opportunity to participate in this research competition.
Thank you for your presentation. I will now open it up to the judges for questions.
So I'll start off just in terms of defining the population as COVID-19 positive. Were you going to use PCR or antibody testing?
So that is actually, hi, this is Dr. Anthony, Thiel Anthony. So our plan is actually just to gather the data. We recognize that there's going to be a lot of variations of actually each hospital from the start of the pandemic. So the variations are actually quite significant. So at the start, there were some hospitals that were not testing the mothers. There were some hospitals that were testing only the mothers and not the newborns. I think once AAP sent out a guidelines, if I remember correctly, I think it was April, there was a little bit more uniformity on how to handle the mother-baby dyads in terms of diagnostics. So that is also, we're going to take that into consideration as well. So we're hoping that once we get the data, we would be able to at least have a more uniform population, and then we're going to look into that as well. So we do recognize that there is going to be some variation, significant variation, especially early on during the pandemic.
Hi, it's Stephen Stanhope. I'd like to ask one or two questions. I was very pleased to hear that it looks like you have estimated approximately 170 mother-infant pairs and such. And so there appears to be perhaps a great opportunity to collect some wonderful, at least pilot data to indicate, you know, what the phenomenon might be and what they might be experiencing. I was very interested to kind of pick your brain a little bit with regards to mechanism of action. So, you know, you believe the COVID-19 from the mother has some sort of impact on the infant. And do you anticipate that that's kind of behavioral, or is it biological, or is it medical? You know, what's your fundamental basis for predicting kind of cause and effect? And I realize this is more hypothesis, but I'm really interested in what you think your theoretical mechanism of action is.
Okay, so well, at the very onset, we're all assuming that there is, after the infection, there is viremia. So the virus is in the mom's blood flow, and so there is the possibility of transplacental transfer of the virus. And we're really basing most of our information on this SARS-CoV based on our initial our studies and our experience on the pandemic, and also the H1N1 pandemic, and also Zika virus. So basically the pathophysiology is viremia, transfer of the viral particles to the infants. And we know that there are some infants that are affected with prematurity. We know that the virus has been cultured and has been actually found in the babies after birth as well. So, but in terms of specific pathophysiology or what actually we're looking at, so we're looking at basically all parameters, both growth and development. And like I said, there's, just like the presentation said, there's really paucity of information on this. So whatever information we can get and we can glean from on what exactly the pathophysiology, and if there's any that we can actually get information from, this is what the study research is for.
if I could just have a quick follow-up, the methodology that you're proposing, do you feel as though could you describe the extent with which that methodology may be generalizable to other pandemics in the future? Or do you feel as though it's highly specific for this particular pandemic?
Didn't think about it that way. I think it's going to be highly specific to this pandemic. This is, I don't even think it could be relatable to the other coronavirus infection that we have, maybe the SARS-CoV-1, the coronavirus one that we had. I don't think it's relatable to that. This virus is just with the adult infection is showing a significant different presentation, different effects on humans that I don't think we can actually generalize this with other viruses. And this is just my feeling. This is certainly a novel virus that has not affected the human, human beings in any other way. So I don't think we can generalize it. So I'm looking more towards this is actually a very unique infection. And that actually has prompted me to be very interested on because of my background in primary care, is really how does this unique infection affect our babies.
Okay, thank you.
I have a couple of questions. First, I'd like to say that was a very, very nice presentation, and the project is, obviously of tremendous importance. And so I congratulate you on its formulation and the methodology. My first question relates to your high yield data that you'll be obtaining. And you mentioned you'll be following the rate of postnatal COVID-2 testing, readmissions, emergency department utilization and growth. Will you also be capturing neurodevelopmental milestone data?
Yes. That actually, the reason that it's actually one of our main data we really wanted to look at was because after the newborn period, we want to see and follow these babies, both through growth and development. So we're going to look at neurodevelopmental. We are still debating on what neurodevelopmental testing we're going to be doing. We are limited to the fact that we are now, some of this will be historical data from March or April. So, but moving forward, we're really looking at what kind of neurodevelopmental testing we're going to do. I think Delaware is unique as a board member of the DCHN, which is the Delaware Children's Health Network. We are actually, I think we're capturing about almost 75% of pediatric population. So we have 12 primary care practices, and they're all integrated with Nemours, who also has 12 practices north to south. So we're all integrated electronically through EMR, through Healthy Planet. So that actually allows us to actually look at every single, if we're going to do chart review, we're going to be able to see every single chart of these babies and follow them through from birth to the end of the research. So that I'm very, very, very excited about. So Dr. Paul, who unfortunately is a big part of this research, he's doing the maternal perinatal part of it. I'm doing the, after birth, growth and development part. So our collaboration is sort of perfect because he has that, mother baby dyad perspective, and I also have the primary care growth and development part of the research. So yes, we are very, very excited about actually utilizing the DCHN as a resource for this research.
Okay, thank you. Well, you've partially answered my second question, which is, are there anticipated challenges with being able to access EHRs between multiple hospitals, care centers, and private practices?
So we anticipate that there's going to be not as much. I mean, as of now, so of course, all the Nemours practices, all 12 practices are electronically integrated. So with Healthy Planet, as far, I think with our recent meeting, we have about almost 8 to 9 out of the 12 practices that are integrated as well to Healthy Planet. So that makes the job a little bit easier for us. But we have commitment from all those drug practices that if we do need to go into their practice and actually just look at their chart and then do a chart review, that allows us to do that as well.
Terrific. Thank you.
Thank you. We have time for one more question from the judges, and I'd like to remind our audience members they may submit questions via either the chat function or the Q&A function within the Zoom.
I'll go ahead and ask a question. Great presentation. Thank you. As we've been listening to the physiological, the clinical manifestations of COVID-19, are you going to be looking at all about the mental health and well-being, in particular of the mom, as you're going through this, if only as a secondary marker of overall wellness?
We actually, that's a wonderful question. I had thought about that initially. We are certainly going to seriously look into that as well, but not in the original, that was not in the original research proposal that we were talking about. But I think our focus on, social determinants of health and, the disparity on what affects what population is affected by COVID-19, we certainly would be willing to look into the mental health as well of these moms. That's certainly could be a possibility. The only problem is that we don't have the chart for the mom. That's not going to be available to us. We only have the chart of the infant, and then we'll have the chart of the infant as the baby gets older. So our ability to access that information will be limited as well.
Right.
Thank you so much. I'd like to just remind the audience that they are able to submit questions via chat or Q&A. We'll wait another moment to see if any questions are submitted.
All quiet on the Western Front.
It is. I want to make sure if someone's typing, I'm just giving them time. We'll wait a few more seconds. Oh. So a question has come in from the audience. The question is, have you had conversation with DIN to make data easier to interpret? Thank you for your question.
No, that actually was brought up initially. We might not get all the information that we need through the DIN because we really need to get into the mother-baby dyad. So our original plan was really to utilize more chart review, not utilizing the DIN. So we're actually going to go through directly to the primary care practices of the moms and the babies that we identify. But that was actually brought up in one of our conversations in one of our meetings. That could be a resource that we can also tap into. I'm just not, we might need to look into what information the DIN has. I don't think they would have like day-to-day, like well checks of babies information in the DIN. I'm not sure if that is actually available. So, but we are going to look into that. But we have that, we have thought about using the DIN as well.
Thank you. Seeing as there are no further questions from the audience at this time, judges, we will move forward with a 10-minute break to allow you to score the presentation for Group 1. For our audience members, please feel free to utilize this as a technology break, and we'll see you back at 2:40. Thank you so much. I'd like to welcome everyone back from our break. Dr. Smith, as you have Group 2 ready to present, please let us know that the timer is set and Group 2 can begin. We'll wait your cue. Thank you.
Hello. I missed the last part. Can I begin?
Yeah, hang on a second. Okay, Matt, the time is 2:40. You have 15 minutes starting now.
Thank you. So my name is Dr. Matthew Saponaro. I'm working with Project Darien to develop a scalable infrastructure to support localized epidemiological models that inform policy and decision-making during the COVID-19 pandemic. Our team consists of an army of PhDs and a grad student spanning from cardiovascular, behavioral health, chemical engineering, and computer science. Our team members are award-winning and the best of the best. For example, Dr. Wagner from the Chemical Engineering Department just received the highest possible faculty award, the Francis Allison Award at the University of Delaware. Dr. Barris received the Albert Nelson Marquis Lifetime Achievement Award. I myself, along with Dr. Dominic and Dr. Szyminski, has just won the highest impact award from Horn Entrepreneurship for a business model to support our COVID-19 project. Dr. Nayak, the director of the Cardeza Center for the Vascular Biology Research at Thomas and Jefferson University, has received the Dean's Transformational Science Award multiple years in a row. Our team combined has nearly over 700 publications and just recently received the National Science Rapid COVID-19 grant to develop a localized population balance model for COVID-19. This is the opportunity that we have. State-level epidemiological models have demonstrated their abilities in correctly predicting the effects of the last 2 COVID-19 spikes for Delaware, and is in the process of estimating the 3rd spike. But given all the information available, researchers are unable to tie back to what is causing the spikes. The current level of data, the granularity used in today's models, is too coarse to provide insights to make actionable decisions by policymakers and interventionists. In order to inform state policies, we need to improve the available data by looking at localized, site-specific COVID-19 transmission behaviors. It is well known that COVID-19 is spread through behaviors, yet we don't have objective methods to assess the behaviors. Our NSF grant helped utilize video-based solutions to capture transmission behaviors such as mask adherence and social distancing in order to inform policies at the University of Delaware. We're here today to request $50,000 to scale our artificial intelligence-based solution to quantify COVID-19 transmission behaviors across spatially and temporally distributed locations and run a large-scale, multi-site COVID-19 transmission behavior assessment across the state of Delaware so that we can evaluate and eventually individualize effective site-specific policies and interventions. This is our opportunity to get rid of COVID by going from defense to offense, by nipping COVID in the bud. We propose to quantify transmission behaviors like social distancing and mask adherence in real time with respect to the environmental factors like sidewalk design and amenities that may influence the transmission behaviors using video processing technology. No other research combines on-site real-time video data for forecasting and policy development. There's no other large-scale surveillance methods that exist to objectively quantify COVID-19 behaviors to inform population-level interventions and policies. The proposed technology has the potential to conduct national and global-level COVID-19 behavior assessments simultaneously, from the East to the West Coast, from China to the US. The research we propose provides a scalable, low-cost, objective, and accurate method to utilizing existing security cameras within organizations and supplemental usage of drone and wearable video glasses to capture localized data in various locations, indoors and outdoors. This can include corporate campuses, zoos, aquariums, schools, universities, hospitals, trails and parks, basically anywhere. For this project, we plan to study in 3 spatially distributed areas: Newark, Wilmington, and the beaches for 3 months as continuously as possible. We plan on using drones and wearable video glasses to sample areas for minute-long clips. But for stationary videos, we're planning to obtain 24/7 surveillance. Just to emphasize, most places already have cameras set up that we want to tap into. If anyone goes to the beach, There's a website called www.visitdebeaches.com, and they have 24/7 streaming of the boardwalks, of the shops. We can just access it. We're planning to just use those video footages and process them through our system to examine social distancing and mask compliance at the beach. For other security cameras that aren't already publicly available, they come with a standard that called real-time streaming protocols, which allows for organizations to send us their video data automatically. And most organizations are willing to provide their data because they don't want to be shut down. They don't want to have their employees sick. They don't want to lose customers. We're capturing and making use of their on-site data to not only help decision makers design policies, but also help businesses identify weak points and operate safely. Finally, by using an automated video processing system, we're standardizing the assessment and improving data quality and quantity while reducing the cost and removing the human observer subjectiveness. So how does this work? It's a three-step process. We first capture the video data, then we process the data, then we report the data. We capture the data by going out on site and taking high-definition drone and wearable video glasses. There's a whole slew of data capturing protocols that we previously developed from our existing COVID NSF work. And then there's the stationary camera footages that we can get from the real-time streaming protocols I previously talked about. As of today, we process video data using our computer vision techniques like YOLO to detect mask adherence and social distancing, age, gender, calories burned, physical activity type if there's any. And YOLO is a lightweight framework for traditional detection problems. We feed data in our machine learning agent, in which it uses to train the model. Then for other videos, the trained model outputs annotations of mask compliance and social distancing and the other variables that I described. Our existing solution runs on a single computer and takes nearly 100 times the duration of the video to process. For example, if we take a 60-second clip, it'll take 60 minutes to process, so we can't scale right now. The computational requirements for these types of video processing algorithms are heavy. We're proposing a cloud-based solution that will be able to scale spatially and temporally so that we can compare the transmission behaviors with respect to the environmental influences as the pandemic progresses. The proposed research is multifaceted. From a computer science perspective, we would develop and compare various mask compliance and social distancing algorithms with respect to the computational speed and detection algorithms. For example, if we detect a person, then take the upper 1/3 of their bounding box, so looking at their head, should we use a simple computationally friendly algorithm that looks at disparate pixel values to capture color differences between mask and skin tone? Or should we use a more sophisticated algorithm like deep convolutional neural networks like YOLO? And the answer to that kind of depends on the camera feed. So we're planning on to tie back this metadata to the algorithm selection. Other questions include, can the choosing of the most accurate algorithm with respect to cost be automated or learned? How does the bucketing of the data affect the model performance? And what aspects of the collected videos can be reused to develop tailored site-specific models when computing resources are shared? Or how do we quickly tailor site-specific models when data is not allowed to be shared due to privacy concerns? All these algorithmic choices affect the development of the cloud-based infrastructure. So in order to test and evaluate this, we're going to develop benchmarks using sample data across different times like morning, noon, evening, and night, and locations like Newark, Wilmington, and the beaches over a 3-month period, and manually annotate sampled videos to create a ground truth. Annotations are conducted using bounding boxes, and bounding boxes are essentially coordinates that label a portion of the image with something meaningful. And this may include something like a timestamp, or whether it's a person, or whether it's a bike, and the behaviors of like whether they're wearing a mask, or whether they're not wearing a mask, or whether they're not wearing the mask properly. And so we're going to use the manual annotations performed by human experts. Then we're going to compare that with the output of our automated COVID transmission behavior detection models. We're going to examine interclass correlations, mean absolute percent errors on the counts of people, the people wearing masks and the people wearing masks correctly. Once the cloud-based solution is developed, we plan to examine the captured transmission behaviors across the state and create a real-time dashboard that shows the COVID-19 transmission behaviors, statistics, as well as key population descriptions like age and gender and activity type. And from this dashboard, we can analyze who's at risk. We're planning to take this a step further by combining this localized data with statewide zip code-based data so that we can feed it into the COVID-19 population simulation tool that Dr. Wagner and Dr. Barris on our team has developed to evaluate policy and interventions design. Right now, nursing homes and assisted living facilities are running rampant with COVID, and the school systems are planning to reopen when we're nearly at an all-time high. People are asking what needs to be done in order to reopen. Well, by combining the real-time, localized data that we're proposing to collect with an existing population simulation tool, we have the potential to inform policymakers about what needs to be done. We can address questions like, at what level of infection in the local student or public population should a classroom or building or the entire school or university be shut down? Should the university stagger class start times or end times to avoid large movements of students between classes, dining halls, student centers, dormitories, recreation facilities at common times? We have the power to address hypotheses like, should traffic at certain intersections where people cross roads be administered by a crossing guard to avoid people being stopped while waiting for traffic? Or better yet, should sidewalks be marked as directional? As are restrictions to traffic and helpful to allow for social distancing at eateries with more outdoor seating? Aside from the school setting, we've talked with Planet Fitness, Buffalo Wild Wings, and even Disney regarding our COVID-19 assessment technology. Disney has found that people in their parks are willing to wear masks, but just forget to put them back on when they go to eat or drink. They were interested in evaluating their intervention efforts, which includes Goofy wearing a mask, running around the parks to promote mask adherence. They're interested in quantifying how many people were wearing masks before and after their intervention to see whether if they should change their intervention strategy or not. The research we're doing uses localized data and is novel. No one else is doing it. However, the beauty of all of it is that we combine this novel data that we have with other data sources, like Christiana Care's contact tracing program and the stateside zip code level statistics. There's so much more value that we can create when we're working together. So if we were chosen for the $50,000, we would develop this scalable infrastructure, conduct a multi-site study, and fuse the captured data back to the statewide data and put it in the existing simulation tools and make appropriate changes to inform policy design. So we would like $25,000 for developing a scalable infrastructure to process the videos. And this cloud-based infrastructure will support the automated processing of the collected videos and providing key COVID behaviors with temporal and spatial context. We want like $5,000 for data acquisition and computing costs. We'd hire $3,000 for hourly wages for drone data and wearable video glass collection, and $2,000 for the appropriate processing of those videos on the cloud-based infrastructure. We would like $5,000 for designing and developing a data dashboard to report COVID-19 behaviors and statistics in the captured populations. And we would like $15,000 for analyzing the quantified behaviors with respect to the DHSA data and design meaningful reports that policy designers could utilize. Our research is 100% sustainable. We have state support to get this implemented across the whole entire state. The Lieutenant Governor, Dr. Bethany Hall Long, head of the Pandemic Resurgence Advisory Committee, and Pulse Tanner, the policy director, have stated that this solves 90% of issues for businesses coming to them regarding reopening. We're actively working together to get this into DHSS, Dover Municipality, and the Newcastle County Chambers of Commerce as a means to measure health risk for the economic reopening and to guide statewide policy design and implementation and reiteration. Karen Hartley Nagel, Newcastle County Council President, is working with us to get into the city of Wilmington, Newark, and Middletown municipalities. She particularly has stated that this system could be supported using the CARES Act to pay for municipality usage. On the same note, we've been working on data acquisition and commercialization aspects with the Delaware COVID-19 Partnership. The Delaware COVID-19 Partnership provides end-to-end COVID-19 prevention solutions to reduce the impact of COVID-19. So things like PPE, janitorial services, business continuity, and health assessments. And we're constantly looking for new members to help fight COVID, and would love to collaborate with anyone here through the partnership. Our website is delawarecovid.com. So long story short, we can use the CARES funding from the government to pay for the COVID-19 assessments up to $100,000 per business, which will help us to get more data and financial support for more research. External to Delaware, there's interest from organizations like Disney and Planet Fitness. But just to be clear, we need your help to scale right now in order to handle their needs. Finally, all this will also provide preliminary data to support an R01 or COVID NIH project, which we're planning to submit. We're planning to correlate captured behavioral data to clinical cardiovascular data. We expect this collaboration will support interdisciplinary research in behavioral health, cardiovascular health, chemical engineering, and artificial intelligence, and strengthen and further facilitate future DHSA collaborations. So thank you all for listening to my pitch. My name is Dr. Matthew Saponaro, and please choose our pitch to fight COVID. Thank you.
Thank you for that presentation. I think you came in just under time, so congratulations. I'd like to now open it up for 10 minutes to our judges panel for their questions.
I have a question. This is really, innovative, collecting all this data, especially behavioral. But one of the questions I wanted to ask you is if you've considered environmental factors, because it's really impacted not only by whether you wear a mask and physical distancing, but the humidity, temperature. So.
And also, as well as the sidewalk infrastructure. So how big is the sidewalk for people to walk by? So yes, we have, and we've done similar work. We previously worked on a project we called Block Walk. And basically it provided an assessment for the walkability of a particular area and how much interaction or how much people are able to just go through that area. So yes.
Cool.
So along those lines, just in terms of your modeling, is there any concern in terms of seasonal changes? So you mentioned the beach, and obviously density changes as we go into winter, not to mention more indoor activity and things like that. How do you handle that?
So the goal for this project is to it's to run an initial behavioral assessment across the state. That will get us to today. Also, the infrastructure that we're developing is supposed to be longitudinal. We're planning to be able to continue 24/7 surveillance over as long as we possibly can. So as we get more data, the statistics and the processing, so we'll process the video data, it'll update the statistics, it'll update our models, it updates itself essentially as we collect more data. Yes, behaviors change. And so there's an immediate short-term change, and then there's the long-term change. Your question's on the long-term change. For the short-term change, you have to keep going out to the site in order to get a reasonable estimate, a reasonable sample, so it's become stable. For the long-term side, that's completely exploratory, and we need to figure that out.
One quick follow-up then, how does the COVID-19 vaccine, and how are you going to be able to incorporate that into any of your modeling? Because that obviously changes, you may see someone on the video, but if they have a vaccine, they're really not playing a role in transmission.
So this is a data capturing system which is fed into a simulation tool. One of the parameters to the simulation tool is to be able to, it's the transmission rate, and it's what you're describing as the vaccine. So that will affect the simulation tool. And so that will help with the predictive components. This is more of an assessment component of the data capturing the predecessor in order to make those next step decisions like you're talking about.
Somewhat related to that, there's a lot of literature. There's a lot of work being done understanding the transmission of the virus, the immunity that some individuals have, and it may be a lot to other coronavirus strains. So is your model able to take into account results that come out in the literature, not just the data that you capture, but information that may come from the scientific literature or other sources?
So so I wish I could send you a link, a URL. So that's exactly what we did for our initial study over at the University of Delaware. We did a literature review. We used those papers that are out there already published and put them into the model. That's how we got our initial variables for the equations. It's a bunch of let me try to, it's differential equations that we use, and there's some coefficients associated with each of them, and then we tuned it to the university setting.
Thank you.
Dr. Sapernaro, thank you for that very compelling presentation. This is a very cool and highly sophisticated project that you're undertaking. My question to you is maybe a little odd, but you know, there's at least 35% of the population that feels they shouldn't have to wear masks, they shouldn't have to social distance. And I'm wondering what you would say to somebody like that as you walk down the beach with your video glasses, where they may feel like you're infringing on their privacy.
Right. So the original comment is there's a whole set of behavior change mechanisms, and the people that are unwilling to wear the mask, I'm going to make a very strong analogy, because our original work is in Fitbit related work, relating to Fitbits and trying to get people to not sit down all day and, you know, be a little bit more physically active. And it's the same type of behavior change theory that's associated with it. So there's people that are in pre-contemplation, there's people in contemplation, there's people that are ready to make the action. And those people are earlier on in the spectrum. So we need to get them up to the next level. Relating to the privacy concerns, the thing is that at the beaches, particularly at the beaches, is that they have web accessible cameras, and so people, when I talk around with people and say, hey, you know about those cameras at the beaches? And they're like, oh yeah, that one, I can see myself. And they kind of have a laugh and a joke about it. So we're using those videos that are already out there. Maybe this is more so on the, you know, but with the wearable video glasses, they're kind of discreet and you can't really tell that they are glasses. But the privacy concerns is that whenever someone's in a public area, the expectation is that they could be potentially videotaped. And so that is a concern. That is a concern I guess some people would have, but it's also an expectation that should be, you know, kept, because that's what the guidelines are.
Matt, I would also chime in in that it's a policy that allows people to be videotaped, and the unobtrusive nature of the wearable glasses helps detract from some of that feelings of uncomfortableness or just behaviors that change because people know that they're being observed. Right.
Hi, I've got a couple of quick questions for you here. The overall concepts that you're presenting are really exciting. And so, you know, I think the entrepreneur would sit down and say, you know, if we can do this, then we can do this. And if we can do that, then we can do this. And it grows bigger and bigger. And we're going to cure COVID-19 and all kinds of things. And I believe that the general trajectory that what you presented is absolutely valid and such. But there are very specific hurdles that you have to overcome to get to each stage. And it sounds like, you know, the data collection that you're doing initially means that you can collect high resolution data, you can control a little bit with the drones and the glasses and things like that, but that's not scalable. And so I see this really as a feasibility project to say the extent with which you can analyze data with automatic principles to come up with mask, no mask, is it appropriate and such. So could you quickly run down what are the 3 or 4 key outcomes that you would demonstrate back to Delaware Health Sciences Alliance that demonstrates the fundamental principle is feasible?
Yes. So we would look at, so we're looking at the infrastructure development component. And
Correct.
So in scaling the infrastructure component. So we do
I'm just interested in the capability infrastructure component to actually make the measures that you're interested in outside us. My next question is going to be on scalability. This is feasibility of the infrastructure. And actually, what are the measures that you'll make that you could report back that says, we did it? It's actually feasible to do this.
So the goal would be to take 24/7 footage and have a reasonable accuracy amount. So being able to keep up with that 24/7 surveillance from our algorithms perspective.
Yep. So, and you can do that with the drone or the glasses and things like that. Now, with regards to scalability, I would really suspect that to really scale at appropriate levels, you'd have to deal with kind of the resolution and such of those web cameras that are out there that people know about that's public. You'd have to be able to perhaps automatically mine videos and information that's on social media.
No. So we have the power over the drones and the video glasses. So that's our system.
To demonstrate feasibility. So now with regards to scalability, you're
tapping into the stationary cameras.
Use drones and continue to use glasses in terms of scaling it to different events and such?
And the stationary cameras. So if you can imagine that there's, say, Little Sisters of the Poor, that they have the security cameras all throughout their system, we will be accessing their existing infrastructure. So they would just be sending us over video data. The standard for today's video systems are 720p. So 480p, we don't really see any of those that much.
So just to clarify, Matt, the level of scale that you're currently looking at is really kind of activities associated with, say, an establishment or a group or a venue?
For right now, we can handle an establishment, a group, or a venue. The scale that we're looking to achieve is statewide or even global assessment simultaneously. So basically, we need to distribute this enough and look at how each of the different things perform with the infrastructure. So we need to pare back the processing to be at this single infrastructure. Is a processor able to process that set of video footage?
So scaling up for you, say, to statewide, doesn't mean jumping to social media or webcams, but it really is scaling up to get the infrastructure of the cameras and the technology in different locations.
Correct.
Okay.
And just to be very clear, it's to process the video data from multiple locations.
Oh, yeah.
So it's not just like, we're planning on getting there's several cameras from the beaches, there's several cameras from Newark, there's several cameras from Wilmington. So that's a whole that's a lot of 24/7 surveillance that's happening. And so that should give us enough data in order to say, okay, can we actually scale? Are the algorithms accurately detecting? Are the algorithms effectively receiving high enough accuracy in order to make reasonable, say that it's reasonable? And the thing is that what we want to do is we can compare this back to how would a human do? And so in our initial exploration study, a human would miss a lot of data. More particularly, when there's lots of people, the human wasn't able to process it all. So by introducing this automated solution, if we can achieve what the human can do, that's a win in my book.
Thank you for that. And thank you, judges, for your questions. We will move on now to questions from the audience. Dr. Smith, do we have any questions in our Q&A feature?
We do have one, and actually it works out rather well because Dr. Sapura was just talking about that. But it is, given the statement that 60 seconds of video surveillance requires 60 minutes of compression time, does the team propose a way to process the hours of video from multiple sources more rapidly in your project?
Yes. So the 60 seconds of video surveillance requiring 60 minutes of processing time is what the current system is today. So the goal of having this cloud-based infrastructure where we have data coming into these buckets, and once these buckets get to a certain field, there's some Lambda functions that are generating and create multiple processors that can handle each of the parts of those buckets. That should be able to help us scale.
Okay, thank you. That's the only question from the audience we have.
Great. Thank you. All right. Seeing as there's no other questions from the audience at this time, we'll move on to judges scoring. So we'll take another 10-minute break and we'll see everyone back here at 3:19. Thank you all. All right, everyone, welcome back. Dr. Smith, on your cue, we can go ahead and get started with group 3. Thank you.
All right, group 3, you have 15 minutes starting now.
Thank you very much. Good afternoon, panelists and audience members. Our project is entitled Using National Best Practices to Inform Mental Health Treatment for Delaware Healthcare Workers in the Wake of COVID-19. My name is Sam Van Horn, and I'm a Senior Research Associate at the ChristianaCare Center for Work-Life Wellbeing. I will briefly introduce my collaborators. My team includes Dr. Vanessa Downing, a licensed psychologist and director of the ChristianaCare Center for Work-Life Wellbeing, Dr. Maureen Leffler, a pediatric rheumatologist and chief wellness officer of Nemours Children's Health System, and Dr. Megan Call, a licensed psychologist and associate director of the Resiliency Center at the University of Utah Health. I will now ask Dr. Downing to talk about how our innovative project will improve population health in Delaware. You're muted, Vanessa.
Okay, hi, thanks so much for having us today. Prior to COVID-19, there were unique risks to healthcare workers that were well described and documented in the literature, especially in terms of mental health. So problems like substance abuse, death by suicide, burnout, the second victim phenomenon, vicarious trauma, compassion fatigue. These are all terms that some of us in the room here may be familiar with. Just looking at a brief review of what we know from some of that literature, after adjusting for confounders like age, sex, hours worked, and relationship status, we found that researchers have found that physicians have a 39% greater odds of having high burnout compared to other US working adults. Compared with other professionals, male physicians were found to have a 70% higher mortality rate attributable to suicide and self-inflicted injury. And women physicians, their increased mortality rate is even higher. The risks aren't just to clinicians themselves. Experiencing symptoms of burnout is associated with a greater likelihood of engaging in suboptimal care practices, as well as a greater likelihood of reporting having made a medical error. We've been closely following caregivers across professions throughout the pandemic at ChristianaCare, and our survey suggests that COVID-19 has introduced a variety of stressors among a group already at risk of burnout or other important negative outcomes. In addition, there are financial implications associated with clinicians exiting their fields and with healthcare workers delaying necessary mental health treatment. A study examining burnout and its association with physician turnover at Stanford found that physician recruitment expenses related to burnout alone were between $15 and $55 million over just 2 years of recruitment. And estimates are that depending on the specialty, it can cost systems anywhere from $250,000 to $1 million to replace one physician who leaves the field. All of the above was well established before the pandemic. And since then, we've seen healthcare workers who are already pushed to their limits confront the reality of living in a chronic state of pandemic. Their rates of trauma, exposure, and stress disorders are clearly on the rise. Now, again, before the pandemic, work-related PTSD for healthcare workers of all professions, especially those working in the ED and ICU settings, was found to be significantly higher than the general population. And healthcare workers are not only more likely to experience PTSD, they're more likely than the general population to attribute the symptoms of PTSD to personal weakness and then to delay getting treatment. So the environment of healthcare is one in which, the denial of personal health needs combined with attracting highly driven, gifted, intrinsically motivated high performers creates a unique risk for delaying much needed care. So our work in healthcare worker well-being is focused on the critical task of reducing stigma and increasing appropriate health-seeking behavior. And our experiences at ChristianaCare have shown success in these efforts. Our rates of help seeking, whether measured by consultation and referral services we provide, or by the individual and group support sessions we provide on demand, following particularly difficult clinical events, show an increase in appropriate help seeking behavior. However, there's this critical question about the preparedness of mental health workers in our community to treat this very special population of workers. We don't at all doubt the competence of local mental health care providers to diagnose and treat psychiatric conditions, but we do argue that healthcare workers are a population for which mental health providers should be trained to be culturally competent. The specialty of healthcare worker well-being is a newly emerging field, and Delaware is uniquely positioned to be a leader as the state has more dedicated positions per capita than many other states in the country, specifically dedicated to healthcare worker well-being. However, we must learn from the experiences of others in this emerging specialty across the country and apply those learnings locally. Delaware cared about and dedicated resources to healthcare workers before the pandemic. We can and should be on the leading edge of ensuring our healthcare workers in need receive the most competent, most cutting edge treatment. So I want to transition to my colleague, Dr. Leffler, to learn more about the research proposal and why it's compelling.
Thanks, Dr. Downing. As Dr. Downing articulated, there are many arguments to be made in favor of addressing healthcare workers' well-being and burnout. One of those is to really recognize that if we do not address the well-being of healthcare workers, we are not addressing the health of the population as a whole. Not addressing the well-being of our healthcare workers can have profound negative impacts on the population's health. Improving population health, as you all know, is a primary goal of the triple aim of medicine. And we recognize that this cannot be obtained without an engaged, vibrant, and healthy population of healthcare workers. This reality is so certain and the need is so pressing that we now talk about the quadruple aim, emphasizing the importance of the well-being of the healthcare team. COVID-19, racial injustices, and social incivility have added to the emotional distress and have amplified the pre-existing need for appropriate mental health services for healthcare workers. And both ChristianaCare and Nemours have a demonstrated commitment to meeting these well-being needs of their workforce, in that they've both established the role of chief wellness officers and created well-being teams designed to meet strategic goals for their respective healthcare systems. These goals include measuring healthcare worker well-being, recognize these important metrics related to quality and safety of care. In addition to addressing systemic drivers of burnout, both organizations pay much attention to reducing stigma and providing high quality mental health services. Our project proposal is compelling for several reasons. First, the challenges that we have all faced and will continue to face are predictably associated with emotional distress. Although there's diversity in how these challenging times have impacted each of us, we share in a collective experience right now in terms of suffering. And this has really changed the way that healthcare workers are talking about things like anxiety, grief, and depression. This is giving us an opportunity to really open up a conversation and promote long-lasting changes in discussing mental health needs and improving utilization of services for mental health needs. Second, this collaborative effort offers diversity in terms of our professional backgrounds and a really rich pool of resources that we can draw upon in order to really effectively meet the fundamental well-being needs of our healthcare providers.
So this study proposes asking new questions about this special population and giving guidance to the work being undertaken on a national level. Of note, the American Psychological Association has 54 divisions representing various subspecialties. None of these is healthcare workers, but military psychology is one example of a dedicated field to meet the unique specific needs of those who've had varying experiences within a distinct culture, facing predictable stressors, risks, and vulnerabilities. We believe that healthcare workers spend their training and working years in a distinct culture that might be highly influential and important to their treatment. So while there's a tremendous amount of research showing the increased mental health risk to healthcare workers, including higher rates of acute stress disorder, PTSD, and anxiety, there's a dearth of research on how best to care for this unique group. There's also a lack of resources to expand the ability of mental health professionals, so we must upskill the existing resources to better care for this group. We plan to gather information from experts in this emerging field from across the nation to identify best practices and then study how education about these practices impacts the competence of licensed mental health professionals in the state of Delaware via randomized controlled trial. And then we will transition to Dr. Call about the sustainability of our work.
Greetings from Salt Lake City. Very briefly, I'll describe 4 ways this project is sustainable. So the product, the outcome, well, using the outcome from our data collection, the product of this project will be a practical online education module. It'll be utilized and shared in multiple ways. For instance, a licensed mental health professional could use this as individual training toward their licensure. This could be shared with mental health trainees, and then also groups who want to start specializing and really impacting the well-being of healthcare workers could use this as a training. The data collected from this project will probably be part of an iterative process, meaning that the data that we collect will likely suggest that other trainings need to be developed as well, likely for meeting the specific needs of specific healthcare professionals. So this may be a core curriculum that's developed that will suggest that other curriculum need to be developed specifically for physicians, for nurses, for medical residents, as well as employees that are likely that identify in the BIPOC community, so identifying as Black, Indigenous, or an employee of color. This training can be shared widely. So as soon as this study is completed, I'm very interested in moving it to Utah. In particular, I'm interested in sharing it with clinicians who are in an urban setting as well as in a rural setting, knowing that our physicians in Utah who are in rural areas have a hard time accessing mental health services. So when they're ready, I want to make sure that our Utah mental health professionals are ready to help. Last but not least, as Dr. Dowling mentioned, this is a burgeoning field within psychology and likely could be a subspecialty within the American Psychological Association. So thinking about this product, this outcome training from our study, being able to use it as a core training within this newer subspecialty within APA will really make a mark for Delaware and then also be able to contribute nationally to the field of psychology. And I'll turn it over to Dr. Van Horn.
Just briefly, we have a sound research methodology to develop our education program and to evaluate it. Our project involves using a baseline survey of 100 national and 100 Delaware or community licensed mental health professionals to learn about their existing strategies for treating healthcare workers. Respondents who spend more than 0.2 FTE in this work will be asked to participate in semi-structured interviews to help the team learn in depth about how these professionals support healthcare workers, what strategies they specifically use. And we will also survey and interview 20 healthcare workers from both ChristianaCare and Nemours to learn more about what the type of stressors they specifically face. So we're using a variety of research methods that inform us as we develop our content education. The content will be then vetted by a panel of other psychologists, vetted by experts, before we go through the process of building the actual final product. To evaluate the education, we are conducting a randomized control trial. We will randomly assign 60 Delaware licensed mental health professionals to receive the education and 60 to a waitlist control. We will use repeated measures regression designs to test our hypothesis that mental health professionals in the treatment group experience better therapeutic alliance and theoretical understanding of their clients' problems. The assumed outcomes of this project are these. We will achieve a better understanding of the mismatch between the needs expressed by healthcare workers and the treatment approaches of mental health care professionals that serve them. Many mental health providers are trained in academic settings and then established a group or private practices and do not go to healthcare settings except as patients. This knowledge will be essential for improving the ability of Delaware licensed mental health professionals to provide treatment for healthcare workers who will provide better patient care when their well-being is attended to. And this project will contribute to better patient outcomes in Delaware. Another outcome will be the sustainable education module for Delaware that is grounded in research-based strategies for supporting the well-being of healthcare workers. This module will be made available as free continuing education so that the outcomes of this project support Delawareans as well as licensed mental health professionals from around the country. Another outcome is less financial costs for healthcare organizations with an improved mental health infrastructure in Delaware. Turnover costs can be very high, especially for physicians, and Delaware will benefit from better retention of healthcare workers as they are better prepared to manage the stress of working in healthcare during COVID-19. Our team has the expertise that is necessary to carry out this project. Dr. Vanessa Downing, as a licensed psychologist and director for the Center of Work-Life Wellbeing and Christiana Care, has years of experience in developing psychoeducation that has been shown to be associated with improvements in quality of life measures for clinicians at Christiana Care. Similarly, Dr. Call is an expert in resilience, which is an important factor contributing to healthcare workers being able to work successfully in stressful times. My doctoral training as a researcher in qualitative and quantitative methods suits me and makes me suitable for researching this project. And of course, Dr. Leffler's experience as a chief wellness officer working on systemic change is valuable for helping us develop education to support healthcare workers in Delaware. Thank you for your time. We will hope you will support this project to improve population health in Delaware.
Thank you for your presentation and to your entire group. We will open it up to the judges for their questions. I'd just like to remind our virtual audience that if they would like to submit questions, to please go ahead and do so through the Q&A feature function. And judges, the floor is yours for questions. Thank you so much.
I think this is a great study. As a clinician, I can see it in my colleagues, and I think it's ambitious because there's a lot of surveys and a lot of qualitative data, and I'm wondering if you can somehow relate some of your push towards your data towards outcomes, and is anything that you're studying going to be outcome based, or is it much more perceptions through questionnaires?
No, well, these are validated instruments. So in the field of psychology, the conception of therapeutic alliance is a well-researched, well-documented method for understanding that relationship that therapists achieve with their clients. So the outcomes, so we have those validated measures are widely used to evaluate the therapeutic relationship. We have to use qualitative methods because we are literally in a dearth of understanding, that our field has not focused well enough on the specific needs of healthcare workers in terms of how to provide them treatment. So we need to build that understanding inductively through our qualitative methods. We want to ensure that our programming is developed from what we hear and what we learn. While we have some experience in our field, we want to make sure that our research methods generate that. But yes, our randomized control trial is a trial of quantitative measures with measures at baseline and then 6 months after exposure with a validated measure. So we think it will be sound for understanding the effectiveness of our education.
Thank you.
I'd like to ask a couple questions about kind of general principles that you're using to go forward. And I'm not a specialist in your field, so forgive me for getting everything wrong in terms of concepts and such, but you're here to educate us, me in particular. But I'm curious about concepts with regards to, I hear words like, best practices, pulling together the strongest concepts in the field and those types of things. And it strikes me as if, particularly now with COVID-19 circling around, we're in a most unusual situation, and I'd like to start with a quick question. Why do you think that best practices that exist that are out there in the field might be applicable to what people are experiencing now?
So when we talk about cultural competence, and Dr. Van Horn referenced the Therapeutic Alliance, counselors and psychologists really have one shot to get it right in their initial meetings with clients, particularly for clients where there is a high stigma and where there is a perception that needing any kinds of psychological treatment might indicate personal weaknesses, personal failings. And so cultural competence is a real hallmark of the field of psychology, that when we're working with particular specializations, how important it is ethically for us to know the bounds and limits of our own competence of working with any particular group. So while there are definitely best treatment, best practices around particular diagnoses, there are also best practices around the treatment of particular populations, where there are shared environment, shared contexts, and also when there's a likelihood that a particular kind of person is going to kind of coagulate in a particular area. So when we think about the sorts of high achievers and typically high self-deniers that go into fields like medicine and nursing. While certainly we see populations like this in other sorts of fields like military, those are fields where there are whole different contexts, like war and combat and weapons training and exposure to the kind of violence that might be anticipated. In healthcare workers, we actually see them having kind of strikingly similar experience to that without necessarily the informed consent or the preparation. So you have folks who are having a really unique experience, and it tends to be a unique set of characteristics that get someone into the field in that first place. So the very thing that makes them kind of thrive and be ideally suited for that field are the same characteristics that put them at risk and make them vulnerable to what then occurs in that environment.
So I think I think we're very aware of what's happening to a certain extent at this point in time. Certainly, the Delaware Journal for Public Health just came out with articles specific to COVID-19 and had a series of articles about the impact and the stresses on residents, fellows, and such, and the medical community, and the stories were remarkably compelling. And I have to say, full disclosure, my oldest son is in a 6-year residency for oral maxillofacial surgery, and when we are given the opportunity to chat, which isn't terribly often, because all the residents have been put on COVID schedules, which means they're on call 24/7, period. And it's called COVID call. And that's gone on for months and months and months. And many fellows and senior attendings say, do not call me tonight, text me, don't want to be disturbed, it's on you. And so it's really remarkable. And so the need, I think, is quite compelling and such. And that's why I want to harp back to the concept of, so you've got mental health professionals and such, and it strikes me as if the part of the training and the best practices might start to explore things like, are they in a position where they should be passively waiting for individuals to contact them? Or does part of the training possibly with regards to awareness and such that there's an active attempt to penetrate the healthcare profession community? And so I'm interested in, because I suspect historically it's been passive. And I'm curious on our best practices going forward, because if you're just using historical components. So bottom line is, what's your model? And is your model applicable for what people are really experiencing now? Or is it going to have to adapt based on, the information that you're gathering?
Yeah, I would say that, and I'd love to hear from Dr. Call and Dr. Leffler as well. Our experience has been kind of building one half of the bridge, which is increasing the help-seeking behavior and decreasing the stigma, creating many doorways for someone to walk through as they are preparing to be ready to ask for help, to seek treatment. And we create a lot of supportive structures and a lot of levels of support that someone can get. And what we have found anecdotally over multiple years and in discussion with our colleagues across the country who do work like this is that when someone is ready to walk over that bridge, we don't reliably have a great place to send them. Or what we get is a lot of feedback that they did not feel well understood by someone that we sent them to, who we know from the clinical standpoint is entirely competent, but they were not able to meet the needs to build that therapeutic alliance in the way that those of us who have worked alongside of them in healthcare settings, we live and breathe the same, we're swimming in the same ocean as them. And when we talk to psychologists, the handful of psychologists across the country who do similar work to what we do, we're hearing similar stories across the country about feeling like we are immersed in this culture, we understand it, we're able to connect with them so quickly, and frankly, a lot of our colleagues would like to see us, even when it's really not appropriate for us to be the ones who provide the treatment. So we need to be able to do those warm handoffs to people who are going to be skilled at creating that alliance and demonstrating that cultural competence that does not make healthcare providers feel like they need to explain or justify their lives or the way that they've been trained.
So would you suggest that the training with regards to cultural competence is maybe one of the key new things that you'd be adding?
I absolutely would say so. And I'd love to hear from Dr. Cawley, Dr. Leffler. That's my stance, is that the cultural competence is really one of the essential missing pieces.
And I would add that this is, if we think about this from a public health perspective, if you think about a triangle with 3 sections, tier 1, thinking about how preventative programs should be available for everyone. And those are kind of the proactive approaches that you're talking about. So making sure that people have access to things like resilience skills and mindfulness skills and other type of support resources. That tier 2 in the middle is more around like a peer support culture. So if someone has a hard day, they feel better if someone at work reaches out to them and says, hey, are you okay? And then that tier 3, the very top, is when a person is struggling enough that they actually need one-on-one support. And so, and that is the point where we refer, or when someone reaches out. And that is the part where we are struggling with, same here in terms of Utah. If I have a list of people that I feel comfortable referring to, and a person goes and reaches out to them, I want them to have a good experience, because we know that people, if they don't have a good experience immediately, they're less likely to seek out treatment in the future. What we know from that public health model is that about 60% of people, their needs can be met in that initial kind of tier 1 level. That peer support culture is more around 30%. And then that 10% that is starting to seek out more, is in need of help, that is really where that one-to-one connection is met. That said, we know in COVID times that that triangle seems to have been shifting, where more people are needing that one-on-one connection at least a few times. And so we know from some of the literature that more people are reaching out. Even our own services within the Resiliency Center within UHealth has increased 30 to 50%.
Thank you.
So COVID has exposed a lot of health disparities with both health and healthcare. So with your model, are you actually taking into consideration the ethnic diversity of your healthcare population? And you could see that some healthcare providers would have different stressors on them because their community is more heavily impacted. So I'd like to hear about your ideas and your thoughts regarding that.
Yeah, I would say, so, in the Center for Work-Life Wellbeing, in previous years, we focused primarily on physicians and providers, advanced practice clinicians, and our last year has been about expanding our services to all caregivers at Christianicare. So that means all 13,000 employees, no matter what their profession, no matter what their line of work. And what that shows us, we used to think about our workforce in terms of people who were trauma exposed as a result of their work and people who were not. And the people that we put under that category included environmental services workers, transport workers, nutrition, in addition to physicians and nurses who were working at the bedside. They all had elements of trauma exposure in their work and varying levels of preparedness and training for that. And as you can imagine, across those different work groups, demographically, they look very different. And so what we are realizing now is that that old categorization of trauma exposed versus non-trauma exposed, specifically in the work setting, we're now in a culture where everyone is also risk exposed, and that there are financial stressors, there are racial stressors, there are sexual harassment and indignity stressors that far predate what has occurred in COVID. So we have these long-standing chronic problems. And I will just point out that when it comes to elements of identity in the field of psychology, that kind of cultural competency is the bedrock, well-trained, well-addressed. Most psychologists, as part of our continuing education, are required to take particular training every year that speaks specifically to the aspects of self and identity that fuel the different experiences that people have. But this vocational aspect and the trauma and risk unique to someone's work is not an element of that. And it's unless you work in something like military psychology, unless you work in a VA system, but we don't have something comparable to that for healthcare workers.
Thank you. Thank you all. We will move on to a question from the audience. Dr. Smith, can you let us know about the questions?
Yes, we have one question. It says, many healthcare providers experiencing burnout and PTSD are on the edge of their capability. Is there concern that an online training and interview may add to the burden of providers who are already under stress?
So I think we can, it's a very good question. And my colleagues and I are steeped in working in an environment in which we're trying to support the well-being of caregivers who already feel like they don't have time to participate in studies about supporting their well-being. So, I mean, our research is going to be obviously vetted by our IRB. The interviews that we do of healthcare workers are obviously what we have. The budget that we have outlined allows for incentives. These will obviously be opting in. Our experience is, however, that during COVID-19, we conducted a survey early on to understand the perceptions of our caregivers, and our caregivers, though experiencing lots of degrees of distress, wanted to participate. They wanted to tell us, they wanted to make sure their voice informed efforts to improve their work life. And the continuing education module will obviously be, there will be continuing education credits for that. That will be, obviously optional for, down the line for mental health professionals to opt into that. So our research design is taking that into account, that we want to use them to make our procedures as efficient as possible, to collect the minimum amount of information we need to inform our project, recognizing that these are people with a limited amount of time.
And to add to that, I'll just share that it's been recently announced that the Delaware Psychological Association is going to undertake a special initiative in the next year or so to specifically try to find appropriate education for its membership that will then provide adequate continuing education to directly related to treatment of healthcare workers. So this is something that this was just a recent announcement last week, but this is something for which there may already be a pipeline for delivering it.
Wonderful, thank you. Dr. Smith, are there any other questions from our audience?
No other questions at this time.
Great, thank you so much. We will move on to judges scoring then. Thank you all for your presentation. We will come back at 4 o'clock. Thank you again.
All right, I'm going to raise the panelists for the final presentation right now. You don't need to start talking. I'm just going to let you be able to.
Thank you all for still being with us here for as we are going into group 4 this afternoon. Dr. Smith, once you're ready to give the go-ahead, the floor is yours to command.
All right, group 4, you have 15 minutes starting now.
Good afternoon, everyone. On behalf of Dr. Odir Nwankor, Dr. Nicholas Lehman, Dr. Vishal Patel, Dr. Jennifer Safuni, and myself, Dr. Anuradha Settler, we are thrilled to have this opportunity today to tell you all about our project, using virtual reality for mock code simulation in medical education. Regrettably, since the COVID-19 pandemic began, we have lost approximately 1,252 U.S. healthcare workers, with the numbers rising as we continue in these uncertain times. A study looking at the countrywide incidence during the height of the pandemic reported that frontline healthcare workers had a 3-fold increased risk of testing positive for COVID-19 when compared to the general population. Currently, there have been about 21,125 cases in the state of Delaware alone, with the death toll most recently as 645. These numbers continue to climb as we head deeper into the winter months. In a time where the ability to acutely manage resuscitations and codes are imperative to the survival of this patient population, education in this arena is even more paramount. CPR itself is associated with multiple aerosol generating procedures, such as chest compressions, positive pressure ventilation, and airway manipulation. Healthcare workers performing CPR are thus at the highest risk of contracting the virus. Knowing this, it is vital to ensure that those giving CPR are well equipped with the knowledge and skills needed in those stressful times. As of now, social distancing and wearing masks are the most effective preventative strategies pending development of a vaccine, definitive treatment, or both. By definition, this precludes all learners from gathering in learning labs, lecture halls, or small group rooms. For the 450 trainees in the state of Delaware and greater than 140,000 active residents and fellows in the ACGME as a whole, the pandemic has led to a substantial decrease of learning experiences for trainees at all levels. Previously, we largely relied on in-person instruction and simulation of resuscitations and codes. Because of this increased risk to healthcare workers, we had to change the way that we practice and, equally important, the way we educate. Essentially, we had to get really creative really fast. We are proposing an ability to train personnel using VR, virtual reality. We plan on simulating codes in real time with trainees of varying education levels. This allows us to maintain social distancing to ensure one another's safety. Yes, we took an oath to save our patients' lives, but in order to do so, we have to protect ourselves. Now I will hand it off to my teammate, Dr. Safuni, to discuss the importance of simulation in medical education.
Thank you so much, Anuradha. The Accreditation Council for Graduate Medical Education, or the ACGME, began an initiative almost 20 years ago now to improve resident physicians' abilities in patient care delivery and in partaking in evolving healthcare environments. This has led to the development of medical competencies, that is, a systematic way of enhancing the accountability of learners and teachers in explicit domains, mandated for over 15 years. This construct has been implemented into medical education, and standardized assessments of these competencies are required for sustainability. Alongside this, the simulation-based medical education continues to become increasingly more prevalent in the past couple of decades in accordance with improving medical trainee skills, knowledge retention, improvement in ACGME core competencies. There is data to support increased knowledge and skill sets in domains such as resuscitation, airway management, and team training through simulation-based medical education. Over time, the opportunity and styles for adult learning continue to advance, and conventional teaching methods seem inadequate to provide proper training to healthcare providers in rare but serious events, such as in trauma and respiratory arrest. Furthermore, in this socially distanced time of COVID-19 and for the foreseeable future, there has arisen insufficient exposure for trainees. Simulation-based medical education is shown to improve both technical and non-technical skills, and also to provide more frequent opportunities for providers to train for high-stake events. Traditionally, mannequin-based mock code exercises allow learners to practice and refine skills in a safe environment that causes no patient harm. The ACGME has recently accelerated the use of its common program requirements for supervision of telemedicine visits carried out by residents and fellows to care for patients affected by the pandemic, while still requiring that they continue to meet the core competencies. Despite the challenges posed by social isolation and decreased patient volumes, learners still need to be able to respond appropriately to both general patients as well as those affected by the viral pandemic by understanding and demonstrating the type of patient care and contact that is expected. Simulation centers, many of which are still closed, all of which are still limited in resources, are not congruent with social distancing. The personnel needed to operate the mannequins and technology are often not available in these times. The financial responsibility for center startup and upkeep is challenging in these times as well. This makes reserving times to run mock codes or even pre-plan a scenario with staff particularly difficult or even impossible. The current modality is also limited in its availability of items such as radiographs, ultrasounds, graphics, tables, etc. And this is widely variable across centers as well, limiting a realistic experience. Essentially, the inability to vary the clinical environment in a simulation center is often reported as a limitation to learner engagement, retention, and applicability. However, virtual reality modalities, though still in their infancy with regard to medical education, are expanding rapidly. They are immersive in content and realism, and also offer a level of cooperation and interactive distance learning to ensure the continuation of high-quality medical education. And so now I would like to introduce you to Dr. Nick Slayman. He will share with you the exciting world of virtual reality and how it can help us educate the people caring for the health of our friends and our loved ones.
Thanks, Jennifer, and hi, everyone. So I'd like to take a few minutes of my time to introduce the concepts of virtual reality and hopefully paint a picture or tell a story so you can come away with an understanding of what it's all about. So I think at its simplest, a definition of virtual reality is a computer-generated immersive 3D simulation environment. And at its basic, the user needs a headset and they need some kind of hand control to be able to interact with the different things in the environment that's been simulated. For popular culture, the best example of virtual reality play is from the movie and novel by Ernest Cline, Ready Player One. So in a futuristic dystopian society, the characters all want to escape reality into virtual reality where they can be anyone, they can go anywhere, and they can do anything. And imagination is the only limitation in virtual reality. And you may ask yourself, well, how does this tie to COVID? And unfortunately, COVID, has been mentioned by Anuradha and Jennifer, it's changed the way that we teach in medicine. We've been asked to social distance. We're rounding at a distance by telehealth and telemedicine. We've been muffled by our masks, and all our sim centers have been closed. Thankfully, we had a pre-existing relationship with a virtual reality simulation company called Acadicus that's offered a little bit of a silver lining. The Acadicus platform allows us to design multiple realistic immersive environments: pediatric ICU, the emergency department, the outpatient clinic, the operating room. We can really make whatever we want. And we can populate that environment with any kind of custom patient or piece of medical equipment that we need to practice with. And the simulation that comes from virtual reality offers a lot of different benefits. It has a very relatively low startup cost when you compare it to a traditional mannequin simulation center. There's a very small space requirement, only about 6 feet by 6 feet, which allows for physical separation, but you can still be in the VR environment. It's intuitive and user-friendly. There's no need for extensive staff to help set up and maintain it. And you can collaborate with experts all over the country and create your own interdisciplinary team of physicians, residents, medical students, nurses, respiratory therapists who are all in the VR environment acting together and practicing team training. And you may say to yourself, well, what about people that don't have a headset? Well, we've been able to use a platform similar to what we're doing today with Zoom to help include multiple other learners who can learn at a distance and act as the virtual mock code leader. The application of medical education and VR training is, again, only limited by imagination. So next, I want to introduce Dr. Vishal Patel from Christiana Care Health System, and he's going to speak about the implementation of this VR training.
Thanks, Dr. Slayman. Now that my teammates have clearly demonstrated the power of VR, I'd like to share how we'll take some of this evidence from our initial findings and the partnerships that we've had with the Catechus and use the implementation science framework to make this standard of care throughout undergraduate, graduate, and continuing medical education. The evidence is pretty conclusive that VR leads to enhanced knowledge and comfort in managing different scenarios. We intend to initially use this technology for residents and fellows, and optimistic that we'll be able to use the lessons learned and scale to other learners throughout the state and even the country. Our initial data has demonstrated that the students and trainees felt comfortable with the technology, and now knowing that many components of education and training will be virtual, VR has the potential to be the building blocks for medical education transformation. Implementation of VR requires creating real-life clinical scenarios and providing qualitative and quantitative feedback to both the individual and the group of individuals participating. One critical strategy that leads to widespread implementation includes a strong relationship and partnership with the clinical expertise, educational faculty, technical VR design teams, and IP infrastructure and platforms, which Dr. Slayman alluded to. We've already started building these partnerships. So now that the next step is really, how do we align effective utilization of VR technology to the quadruple aim? We know it's going to lead to better clinical outcomes, improved provider knowledge with comfort of common and rare procedures, lower cost to train, and most importantly, improved patient and family trust and satisfaction to the care that we're delivering. We need to create specific measures and metrics for different scenarios to ensure its effectiveness, and we've started to do that with a few of our pediatric ICU scenarios. Once we demonstrate the positive impact of VR in some of these high acuity clinical scenarios, we can scale to multiple care areas, leveraging several clinical partnerships between Christiana and Nemours with management of non-COVID inpatients at Nemours and delivery of high-risk babies at Nemours. Lastly, with the ever-changing guidelines and management of COVID, we can create VR scenarios to practice donning and doffing, appropriately masking, or even treating COVID-19 patients virtually in an ambulatory setting or even within the hospital. I want to hand it off to Dr. Nuankor, who will discuss how we will take this evidence into practice and transform education for the future.
Thank you so much, Dr. Patel. I think that we all know the reason why we are here. There is a problem. And what is the problem? The problem is that the world was hit this year, 2020, with COVID-19 pandemic. What is even so worrisome about this problem is that the infection rate is increasing. It's increasing in Delaware, it's increasing in the United States, it's increasing worldwide. Worse still, the death rate is increasing even among healthcare workers. What do we know about the problem? Life as we all knew it has completely changed for everyone. Unfortunately, the preventive measures that we use to curb this pandemic, things like social distancing, have adversely affected our medical education. The way we train the next generation of medical providers, especially with simulation, has significantly changed. What is left out? There is no standardized, acceptable way of medical simulation across all training programs in Delaware and the whole of the United States. What do we plan to do? Our proposal is to demonstrate the effectiveness of virtual reality mock code for medical education. We would like to present this as an alternative to the traditional mannequin-based medical simulation. How do we plan to do this? This is actually a 2-year study. In our first year, we're going to pilot this project at our 2 campuses, at Christiana Care and at DuPont Children's. And we'll have over 50 volunteer trainees who will do this. In our second year, we also hope to upscale this project to include majority, if not all, the 450 trainees across all the training programs in Delaware. As we do this project, we should be able to show a couple of things. We should be able to show impact and outcomes. To show outcomes, we have to demonstrate that virtual reality is an effective method of medical education. We also have to upscale this project to include all areas of medical practice to enhance proficiency in practice, just like Dr. Patel has actually enumerated. In doing all this, our goal is to build a stronger healthcare workforce in Delaware. One might wonder if this is sustainable. It is. In our second year of this project, when we upscale it, we want to include all the training programs in Delaware. We also want to send a proposal to see if the ACGME would include virtual reality in medical education. We intend to apply for an R01 NIH grant for medical simulation grant. Does our project fit into our institutional priorities? I would say that this project, building a proficient healthcare workforce in Delaware, will positively impact the health of all Delawareans. Let me just say this. It may be a lofty goal, but I think Delaware is ready for a 4-year medical school. We already have 2 tertiary care centers in Delaware. We have a freestanding full-service children's hospital at DuPont. We also have a comprehensive quaternary health center at Christiana. I think we are ready. Our research is a prospective observational study that will use implementation science. Our protocol already has been reviewed and approved by the Nemours Clinical Research Review Committee, and we got a priority score of 2.
Dr. Nwankor, you have reached 15 minutes, so we need you to stop talking.
All right, thank you all. Thank you for your presentation. We'll open it up to judges' questions now for our final group.
So I have a question. In terms of the traditional simulation, and ACLS has training that uses computer interface to get you prepared for the in-person mega code and things of that nature. Have you evaluated the performance of the VR versus that type of, for lack of a better term, simulation? And to know how much more people gain from participating in the VR? Or is that something you're going to have to develop the VR before you do that evaluation?
So I can take this one, Dr. Whalen. I think it goes back to a project that we did about a year ago with one of our recently graduated 3rd-year fellows. And what I compare it to is the difference between watching a video or watching a computer simulation on a desktop and being in the simulation itself. So the study that we designed was a pilot where we took residents and a few fellows who were all novices at respiratory failure and set up for pediatric intubation. We developed a VR simulation where they could put on the headset, be in the PICU virtually, pick up all the tools, handle the bag and mask, handle the laryngoscope, pick out the right sizes of things. And then we took them out of VR, put them in a traditional simulation center and said, based on what you learned in that module where you could interact with all the tools, please set up for an intubation now. And we scored them. And then we compared those VR learners to the advanced fellows, the 2nd and 3rd-year fellows who have intubated 50 to 100 people already in their fellowship. And the p-values showed no difference. So the VR novice learners, after an experience of interacting with tools and equipment in a virtual reality simulation,
Oh, someone just froze.
scored as well as the upper year fellows who had been setting up for intubations. Question? Was there another question?
No, Dr. Slamon, you froze while you were speaking, so we couldn't hear the end of your thought.
I apologize. So we think that the ability to be in VR and really experience the environment handle all the equipment brings the learning up to a different level than if you were just sitting in front of a computer watching someone demonstrate, you know, these are the steps that you should do. You're part of the movie, you're not watching the movie.
I have a question. Thank you for your presentation. You know, clearly there's great promise with including VR into simulated clinical training. Your proposal states that you're going to be looking at various outcomes from these experiences, including you know, improvement in response time between first experience and second experience. You're going to be making some correlations between levels of training and whether or not they've had previous mannequin sim experiences. You're going to be using neonatal, pediatric, and adult models, and also deriving information about the participants' perception of their educational experience, if I have that right. And so I think that these endpoints all make complete sense, and you're going to get a lot of valuable information, but my concern is the numbers of participants. And perhaps this is only for the pilot part, but what I extracted from your proposal, there were 10 fellows, 12 residents, and 5 students. And I think that it's going to be very difficult to get you know, interpretable data from numbers that are that low. So have I missed the point about your participants?
So Dr. George, in the pilot phase, initially, we'll be pulling from people who rotate in the ICU. Mm-hmm. So that's 12 new residents every first of the month.
Okay.
As well as new students that rotate with us every month. The only folks that will be continuous throughout the year is the 10 fellows. Okay. But all the other residents, which are a mixture of pediatric, med peds from Christiana, and then 4 different ER sites, so Jefferson, Inspira, Conemaugh, and Christiana ER residents all rotate with us, and they change every first of the month.
Okay, thanks. One very quick question. The examples that you gave of cases that will be provided to you from the company, none of these were actually related to COVID directly. Were those just examples of what could be done? Okay.
Yep, they were examples designed by Dr. Settler and Dr. Safuni.
Okay, thank you.
Hi, this is Stephen Stanhope. I'd like you to just summarize very briefly what you would feel are the novel components of the training that the novel approaches. With the level of detail that you provided us and such, I really want to just kind of summarize and say, you know, these are the key things that we're doing differently, you know, that really makes it stand out as a novel approach.
So, Dr. Stanhope, I think there's a couple different things that make it novel. If you've ever been in a traditional mannequin simulation center, no matter how expensive the mannequin, that still comes across as a plastic mannequin. Mm-hmm. And in the VR world, we can increase the level of realism and immersion to a point that makes it really novel. And the example I'll give is that when we designed our PICU model, it's based on the Nemours PICU, and I spent about an hour in that VR world. And in my normal PICU time, if I start to get a little fatigued, I might lean on the bed, or I might lean on the table that has all my...
Nicholas, you just froze on us again. You're still frozen.
Equipment. And I found myself after about an hour in VR doing that, and there was no... Any better?
Yeah, you're back live. Yep, thank you.
So to finish up, after I spent about an hour in the VR world, I found myself leaning on the bed or leaning on the table that didn't exist. You kind of forgot because it was so real. It was like you were in the PICU.
Okay, so
it really is novel.
Yep, so that's novel to actually create a model of the environment and such. Are you, and I'm going to just throw out some concepts just to kind of trigger other things that may or may not be novel. Will the environment kind of interact with the participant? So if the participant then starts to execute something, does the environment then, change or adapt?
So the platform is designed to have something called ghost mode. So the mannequin, quote unquote, can be populated by any of us in a VR headset that we can speak for it. We can control its actions. We can control its vital signs. We can change its heart rate, its blood pressure, make it breathe faster, make it stop breathing. So just like a traditional sim center where you have someone in a control room changing the parameters, we can do all that from within the platform itself.
Now, are you planning, so since you'd have that capability, are you planning on having that as a part, built in with some sort of intelligence as a part of the platform? So as the person's going through their experience and they do something that, say, is either appropriate or inappropriate, that the mannequin responds to that? Is that part of the environment that you're planning?
So we can pre-design, and we have pre-designed certain avatars to do certain things. So based on the response of the resident, where they recognize that there's a systole, the heart is stopped, we want to start CPR, we can then trigger a pre-recorded mannequin that we click a button and they start to begin CPR, or they begin to bag, mask, ventilate the patient, or a nurse. We want an IV, the nurse appears, and then we'll put an IV in based on the requests of the code leader.
Okay, so I'm looking for some clarity here, and maybe too much detail, but to a certain extent, do you anticipate that there would need to be some sort of a proctor that's, say, participating, that's going to control this, so that it's not necessarily a fully automated immersion in a virtual environment, but there, in essence, would be a proctor or someone in there that could trigger different things? Is that what you're thinking?
So I think that's part of the budget, and the funding is to have multiple headsets. So one person may be playing the role of the wizard behind the curtain, another may be playing the role of a patient, another may be playing the role of a resident, where a code leader is then telling the resident, we'd like you to put in a chest tube, or we need you to start intubating the patient. So we do want to have multiple headsets to let people play multiple roles within VR.
Okay. Thank you.
We've looked at these as a system from a VR perspective to see if, obviously at Christiana we have 30-something residencies and fellowships and hundreds of medical students that come through. And we looked at the VR companies, and they weren't ready for prime time, except for maybe doing very simple, basic procedures. Is this sort of so innovative? This is the next step of company, and this is the company's way, the vendor, for you guys to test it out? Or are there other comparative companies with some pretty good VR code simulation? Because you're entering the next complex level where VR for putting in a Foley or doing EKGs is starting to get more, that's what we looked at, and they're pretty good. But to take it to that next level where it's interactive and can be function as a code and be altered is very cool. And I'm wondering if this company's really gone to the next level, or there are others out there and this is just one of them.
So Brian, that's a great question. And there are multiple companies out there. What I think attracted us to this one platform in particular is that many of those companies are kind of a pre-programmed video game code. So you do X and Y happens and there's an outcome and you can't change that. And what we liked about this was the mock code ability of having a control room where, all right, well, you got the part where you should put a chest tube in, but now we're going to make them have a systole. Let's see how you react to that. What it doesn't do, and what is not ready for prime time and is not ready player one yet, is it's never going to give you the feel of what does the laryngoscope exactly feel like in my hand as a weighted object, or how much touch do I need to insert a Foley properly, or how much force should I use to make my wire go in the central line. That's coming with haptic gloves and haptic suits, but it's not here yet.
All right, thank you all. We are going to wrap up our questions here from our judges. Dr. Smith, do we have any final questions from our virtual audience for our final group?
No questions from the audience at this time.
Very good. Thank you so much. Thank you again. Group 4, we will ask our judges to take about 10 minutes to provide their scoring and our rubric. And then we'll ask all to come back at 4:40. And if we need a few extra minutes for judges' deliberation, we'll build that in also. But we look forward to having everyone back in about 10 minutes and look forward to announcing our winners. I want to thank everyone again today, all of the groups that submitted, all of the groups today that presented, and of course our judges panel. So judges, if you would please go ahead and score our final group. Thank you so much.
Ladies and gentlemen of the audience, while the judges are doing their final decision, I'm going to launch a poll so that the audience can let us know if they agree with the judges or not. So the results of the audience poll only, not the judges poll. This is just what you guys listening thought, was that group 4 was the winner. And in a couple minutes, we're going to see if the judges agreed with us or if they have a different winner in mind.
And now the judges are judged.
It'll be interesting to see if the judges agree with the audience or if they don't agree with the audience.
How interesting.
Dun, dun, dun. I feel like we need to have like a do, 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 do.
Thank you, Pamela.
Are we open to the public now, or is this just us?
Verbally, everyone is watching.
Oh, everyone's
Everybody's watching.
All right, just checking.
But yes, judges, if you would like to make any comments before the winner is announced, please do so now.
Yeah, I'd like to make a comment for sure. I wish we had $200,000 to give away. I think that each of the submissions stood on its own merit, whether from a solution standpoint or a generalizability standpoint. Very strong, and thank you all for all the thought and work that you put into it.
Thank you, Tim. Would any of our other judges like to make a comment before we announce our winner?
Yeah, it was very interesting because I found myself scoring very high in terms of, is there a compelling argument? Yes, the arguments were remarkably compelling. Is it important to the institution? Yes, I know. So it was really interesting to come up with ideas and criteria, which shows in the scoring. I mean, the scoring range is actually quite tight for this type of a process. So those are 4 really outstanding proposals and really great presentations.
Agreed.
I would agree. I learned a lot. And I think there's a lot of innovation in the state, which is very exciting.
I agree with the other judges. This has been phenomenal. I really have been very impressed with the time and effort you put into your proposals and your pitches. And as we went through all of these presentations, I was racking my brain for additional funding mechanisms. And the only thing I could say is that it seems that all of these are fundable projects, and I wish you all the best to find sources to support your work. And don't forget, the NIH has that program for for pilot studies, not requiring a lot of preliminary data, but they have to be really high for innovation. So I would encourage you to look into those. And I just wish you all the best. Thank you.
Yeah, I would concur with everyone that these were highly innovative and brought forth great concepts and ideas. Each team should be congratulated for being at this point because there's already been a selection process. And For the winning team, we look forward to seeing you continuing and developing your proposal. And for the other teams, you know, I think there are certainly opportunities for funding, and you know, we hope that you continue your work and move your projects forward, because they'll have a significant impact on the state of Delaware and the members of the Health Science Alliance.
Thank you all. On behalf of Dr. Khan, DHSA, and our judges today, I want to again thank all of our groups presenting today for your dedication to serving your community at this unprecedented time of COVID-19. And once again, thank you to our panel of judges for lending your time and expertise to our annual research competition. I'd also like to echo the comments of our judges, again, to all that submitted proposals, and again, all groups today. We certainly hope that your work continues regardless of our outcome today. It is with great pleasure that I announce the winner of our 2020 DHSA research competition and award of the $50,000 DHSA grant. You'll get, oh, you can't see with my screen. Okay, I don't have a lovely, lovely plaque. And more importantly, I don't know if you can see in this time of COVID and digital virtual, no, can't see. There's a virtual check here for $50,000, which we will get you the real one, I promise. But it is with great pleasure that I announce our 2020 winner is the team with the research for using national best practices to inform mental health treatment for Delaware healthcare workers in the wake of COVID-19. The project team, including Drs. Downing, Leffler, Call, and Van Horn. Congratulations to all, and thank you. Thank you, everyone. And thank you to our audience and for all that submitted questions. We greatly appreciate your tuning in, and we look forward to being back here next year for 2021. Take care.
Thanks all.
Well done. Thanks.